Good morning, everyone. We're just going to give people another minute to join. We'll get started very soon. Okay, let's get started. If we could remove the code, please. Good morning, everybody. I'm Eric Nestler. I'm director of the Friedman Brain Institute at the Icahn School of Medicine at Mount Sinai, and it's my tremendous pleasure to welcome you all to today's webinar titled Maintaining Women's Brain Health Throughout a Lifetime. We're very excited about this program, which represents a collaborative effort between the Friedman Brain Institute and the Department of Obstetrics, Gynecology, and Reproductive Science. With us today, I have a co-host, Dr. Leslie Shaw. I'll be calling on her in just a moment, and we'll be bringing to you today three expert panelists, Doctors Chelsea DeBolt, Anna Barbiera, and Anna Pereira. We are very excited about where we are in medicine today, paying attention at long last to the health of half the population of the world. This month is Women's Health Month, and this just notes the fact that attention and consideration and knowledge about women's health and disease has lagged behind that of men for centuries, but we are catching up. And Mount Sinai is particularly excited to be working on several important initiatives to advance women's health and well-being, and we'll have some important announcements to make in the coming weeks and months about these efforts. Let's get started. I'm going to call on Dr. Shaw to introduce our first speaker. Dr. Shaw is the director of the Blavatnik Family Women's Health Research Institute and vice chair of the Department of Obstetrics, Gynecology, and Reproductive Science. Leslie, thanks for joining me as a co-moderator. Please take it away.
Thanks, Eric. I have a privilege to be here with you all today, and I have an even greater privilege to introduce Dr. Chelsea DeBolt. Dr. DeBolt is assistant professor of the Raquel and Jaime Galinsky Department of Obstetrics, Gynecology, and Reproductive Sciences at Icahn School of Medicine. I'll turn it over to you, Chelsea.
Thank you so much. Good morning, everyone. Dr. Nestler and Dr. Shaw, thank you for inviting me to this important event. I am a maternal fetal medicine specialist, so I have the great privilege of taking care of women prior to pregnancy, during a high-risk pregnancy, as well as postpartum. My focus is understanding and advancing women's health through the lens of pregnancy. I often think of pregnancy as a stress test for the body, a period of time in which there are changes that can potentially unmask underlying health conditions for a particular patient and set the stage for future well-being for women. I do think that this perspective is crucial as it can change our view of pregnancy from just a standalone experience to a pivotal event that does provide us with valuable insights into the lifelong health trajectory of women. Unfortunately, it's not well understood how sex-specific factors, including pregnancy, may affect the future health of women. We do know that some studies have shown that certain pregnancy complications, such as things like preeclampsia or high blood pressure of pregnancy, fetal growth restriction, and gestational diabetes, can potentially be early indicators of the future cardiovascular and metabolic health for certain women. And importantly, pregnancy does appear to have potential effects on cognitive health as well. We do know there are hormonal fluctuations that occur during a pregnancy as well as the postpartum period that can potentially influence brain structure and function. Recent research has highlighted the role of these pregnancy-related hormones, such as things like estrogen and progesterone, in modulating the cognitive processes that can include things like memory, attention, as well as mood regulation. Beyond the physical aspects, though, pregnancy also has significant psychological and social implications. It can influence a woman's mental health, her social support network, and her overall quality of life. Recognizing these broader dimensions is, of course, essential, I think, for providing holistic care that addresses not just the medical aspects of healthcare and pregnancy, but also the emotional and social well-being of women in general. Broadly, my work focuses on advancing our understanding of the biological underpinnings that drive clinical outcomes for women during their reproductive lifespan, with a goal of bridging the gap between preconception or prior to pregnancy, as well as lifelong women's health. I'm hopeful that together we can make meaningful strides in understanding the long-standing effects of pregnancy for both mom and baby, and leveraging these insights that we're able to gain between the connections of pregnancy and lifelong health. I'm hopeful that we can develop targeted interventions, personalized care plans that not only optimize pregnancy outcomes for women, but also help us to mitigate those long-term health risks and ensure that every woman receives both personalized and comprehensive care that she deserves.
Thank you very much, Dr. DeBolt. Before we go to the other panelists, let me ask you a quick follow-up question. When you say that pregnancy is a form of a stress test on a woman's body and brain for the rest of her life, it's an interesting point that I hadn't appreciated previously. What about a woman who adopts a baby? So that in that sense, we don't have the effect of biological pregnancy on the woman's health, but still the psychosocial, cultural aspects of the impact. And what is known about that, about a new mom adopting a baby and her future health?
Yeah, that's a great question. So, actually, ideally focusing on what we would describe as non-birthing parents, so a mom who has not physically or have been pregnant, is really important to help us to better disentangle the sort of difference between environmental mechanisms as well as hormonal mechanisms that are associated between really not really pregnancy so much, right, but being a parent and cognitive health. There's actually not a ton that is known about non-birthing parents, and it's sort of a call to action to really focus on non-birthing parents and bringing in some of these other groups, which could include, in the case of, like, for instance, surrogacy, so someone that's been pregnant but may not actually have experienced parenthood in such a way, as well as non-birthing parents, so someone that's not been pregnant but has experienced parenthood. That's a really important place that we need to focus to better understand the differences or associations between pregnancy itself, as well as cognitive health for women.
Thank you. And we'll come back later in the webinar to talk more specifically about some of the health impacts of pregnancy. Dr. Shaw, let me turn things back to you, please.
Great. Thank you all, Chelsea. That was wonderful. I get the opportunity to introduce Dr. Anna Barbieri. Dr. Barbieri is an assistant clinical professor in the Department of Obstetrics and Gynecology and Reproductive Sciences at the Icahn School of Medicine. I'll turn it over to you, Anna.
Thank you so much, Dr. Shaw and Dr. Nestler, for inviting me, and thank you for the audience for being here. I think the first thing I'd like to say is just how excited I am to be on this panel, which really represents, I think, the next chapter in women's health, and that is a chapter of integrative health, integrating across different specialties, different interests, different areas of focus of women's health. I think we all recognize that care has been really siloed and fragmented, and we are here to do exactly the opposite. We're here to actually connect the dots. And that is really my area of focus within the area of women's health and gynecology. I am both a gynecologist and an integrative medicine physician. And in my professional life, I really focus mostly on hormonal health and especially hormonal transitions. In women's health, we have the transitions of puberty, pregnancy, postpartum, and of course, perimenopause and menopause. And that is my main focus. And we already heard from Dr. DeBalt about how pregnancy influences women's health. We also understand that that hormonal transition of pregnancy into postpartum, for example, can give us a window into one's midlife. We know that those women, for example, who've experienced postpartum depression may be at higher risk for mood disorders in midlife. Midlife and the time of perimenopause, which, by the way, can be up to 10 years before that last menstrual period. So many people don't even know that. It's actually a pretty long transition. It's a major time of hormonal fluctuations, especially of the two main female sex hormones, estrogen and progesterone. And those fluctuations are definitely associated with different neurologic and psychological changes, both in terms of mood swings, in terms of rates of perimenopausal depression and anxiety, as well as having an impact on sleep, for example. So up to 60% of women in perimenopause do complain of significant sleep disruption. And if any of you, are in your 40s or 50s on this panel, I'm sure some of you have woken up at 3 a.m. with kind of this sense of overwhelm and not even knowing why the wake up occurred and how to go back to sleep. And then there's also concerns regarding cognitive function and the changes of that and beyond later on. So this is a very, very exciting area where we're starting to, in the areas of gynecology and psychiatry, neurology, metabolic health, cardiology, really to connect those dots. And I'm very excited to be part of this sort of new chapter in medicine. There's lots we don't know. So this is kind of our call to action, especially in midlife. We don't know why some women really respond so significantly to these hormonal changes in terms of their brain health. We don't know exactly how estrogen, progesterone, we're just starting to understand, influence sleep. How much does sleep disruption versus hormonal fluctuation impact cognitive and emotional health? And for example, what role does testosterone play? There's a lot of work to be done in this area. Menopause is a hot topic these days, but we have so much more to do. I am certainly glad that it's sort of brought up to the light from kind of its previous sort of status as a taboo. And I'm just excited about what's to come. So thank you again for having me on this panel.
Excellent. Thank you. Dr. Shah, did you want to ask a follow-up question?
Yes, that'd be great. Thank you so much. That was wonderful, Dr. Barbieri. Maybe you could, New York is such a diverse environment. Our populations are quite diverse, right? Maybe you could give us some insight in your perspectives on how you integrate your discussions around hormonal changes within the context of healthcare equity.
Yes, I think that's a very important aspect to mention. So perimenopause and menopause, while universal transitions for women, are also very individualized. And this season of life can look very different depending on a particular individual. And also there are some group differences also. So for example, we know that certain women, for example, African-American women, report more vasomotor symptoms, while some other groups may, for example, have more joint issues. So it's very, very important to first sort of share the information and educate, make women aware of what this change looks like and what impact it may have on them and on their health, and then really tailor the potential interventions and support to that particular patient, both in terms of what they need, but also in terms of the tools that we use.
Great, thank you. I'll turn it back over to Dr. Nestler.
Yeah, thank you very much. Our third panelist is Dr. Anna Pereira, who's an associate professor of neurology and neuroscience and runs a laboratory focused on brain health and specifically Alzheimer's and related conditions. Anna, I'll turn things over to you.
Thank you so much for the invitation. I'm delighted to be here and in a panel with gynecologists and neuroscientists and neurologists. So I think integrating that is really crucial. So women are more affected by Alzheimer's disease. 2/3 of Alzheimer's cases are actually women. So women do live longer on average than men, and age is the major risk factor for Alzheimer's disease. However, longevity does not fully account for women being more vulnerable to develop Alzheimer's disease. So there are biological factors, and we need a lot more research to fully understand these factors so that you can better prevent and treat Alzheimer's disease. ApoE4, you probably have been reading in the media these days, but it is indeed the most common genetic risk factor for late onset Alzheimer's disease, which is the large majority of Alzheimer's disease. So even though ApoE4 gene has an equal distribution in men and in women, studies show that the risk of developing Alzheimer's disease in ApoE4 carriers is 4 times higher in women in comparison to men between the ages of 65 and 75 years old. So this ApoE4 gene is a risk to accumulate misfolded protein in Alzheimer's disease. So those are those proteins, the typical you see in the brains of patients with Alzheimer's disease, which is called amyloid plaques and neurofibrillary tangles, which is formed of phospho-tau. And studies suggest that women, and in particular those who carry this ApoE4 gene, have a higher risk of accumulating pathological tau than men do. So this pathological, when this tau leaves an area of the brain called the entorhinal cortex and goes all over to the neocortical, higher functioning cortex called associational cortex, that's when dementia really happens. So there is really a strong spatial temporal correlation between when this tau accumulation occurs in the brain and where in the brain it occurs, and what is the cognitive symptoms, the behavioral outcome. So it's interesting that in perimenopause and in postmenopause, the ovaries, which are reproductive organs, reduce production of estrogen, as Dr. Barbieri has mentioned. However, most of the symptoms experienced actually by the majority of women are actually neurological and psychiatric, and such as hot flashes. So that's the hypothalamus that regulates temperature, body temperature. Insomnia, the brain's nuclei in the brainstem that regulate that. Mood and cognitive complaints. So estrogen really promotes glucose metabolism and energy and affects all cell types in the brain. And studies have shown that during perimenopause, there's a reduction of metabolism that you can see through a technology called FDG PET. There are also white matter changes in the brain. So you have the neurons and the white matter fibers, those are their changes during perimenopause as well. So there's this transition to during the perimenopause is a period of vulnerability that can also potentially increase accumulation of amyloid in the brain, which is a risk to develop Alzheimer's disease, in particular in women who carry this ApoE4 gene. I think it's very important to emphasize that those Alzheimer's pathologies start accumulating 15 to 20 years before cognitive decline starts happening. So there's a really long period in which we are trying to intervene, the earlier the better, to improve cognitive outcomes. It's also important to note that this does not happen to everyone. All women go to menopause if they live long enough, but some are at risk of Alzheimer's disease. Not all of them develop Alzheimer's disease. So we really need to understand resilience and vulnerability better. So it's a risk of these hormonal changes in combination with aging that the brain needs to adapt to. And some patients adapt well, some people adapt well, others don't. So a lot more research is necessary to understand brain gender differences and women's vulnerability to Alzheimer's disease in order to prevent and treat Alzheimer's disease. Thank Thank you.
Thank you very much, Anna. So we're going to now ask the panelists several questions to follow up. I want to remind you all in the audience to please ask your own questions, put them in the Q&A function at the bottom of your Zoom screen. I'd like to start by asking the two Annas, Drs. Barbieri and Pereira, about hormone replacement therapy. And maybe we'll start with you, Dr. Barbiera, just in general about the current recommendations for hormone replacement therapy for symptoms of menopause, and then switch to Dr. Pereira to ask specifically about what we know about hormone replacement therapy for Alzheimer's disease, brain health, and other dementias. So, Dr. Barbieri, you first.
Sure. Happy to take that. So the world of hormone therapy has almost done quite a 180 turn in the last few years compared to about 20 years ago. At that time, a certain study came out of which we now know the limitations of that suggested that hormone therapy had really significant risks. A lot of studies have been done since then, and just to, for the sake of time, I'll summarize them. We now understand that hormone therapy, when started around the time of perimenopause or entry into menopause, and here I'll just say menopause is really clinically defined as 12 consecutive months without a menstrual period. So perimenopause and soon after menopause seems to be the best time to start hormone therapy, can actually be quite safe and beneficial for most women. And actually, even the most recent sort of stance of the Menopause Society here states exactly that for women, and especially those who need relief of menopausal symptoms, hormone therapy carries more benefits than risks. We also, there's a lot of details to it. Currently, hormone therapy is recommended for relief of hot flashes, night sweats, and prevention of osteoporosis. But it does have other benefits that should be considered on an individual basis. And like all things in medicine, everything that we do is a risk-benefit discussion with each patient. So my kind of medical and practice philosophy is that all women should know about hormone therapy. Not all women want to or can use it, but everyone deserves to have a personalized and thorough discussion about it.
Thank you. That's very clear and very helpful. So, Dr. Pereira, back to you then. As you were talking about the greatly increased risk that women have for Alzheimer's disease, which is quite striking. We don't hear that much about that in the lay press. Is there any relationship between menopause and Alzheimer's disease specifically? Do we know what effect hormone replacement therapy might have on a woman's eventual risk of developing Alzheimer's disease or another dementia?
That's a fantastic question, Eric, and we really need to study a lot more that. So while hormone therapy may alleviate hot flashes and promote bone health, that Dr. Barbieri has pointed out, the perimenopause symptoms, there is currently no recommendation for hormone therapy to prevent Alzheimer's disease. So there is really a huge need now to study different formulations, dosing, timing during perimenopause, and really well-designed clinical trials that can start giving us good answers about this. We know it's a risk period, but we don't have clear interventions right now. And the great news right now is that we have wonderful biomarkers for Alzheimer's disease. We know that pathology accumulates in the brains like 15 to 20 years before developing symptoms. So the novel studies now designed for prevention with our hormonal therapy and prevention of Alzheimer's disease can utilize those biomarkers in spinal fluid and blood so that you don't have to wait for 15 years. We can accelerate the speed of these clinical trials now that you have those novel technologies.
Excellent. Thank you both very much. Dr. Shaw, would you like to take the next question?
Sure. Maybe I'll ask Dr. DeBolt a question. And maybe, Chelsea, you could focus in on any data related to pregnancy and future cognitive health.
Mhm.
That's a great question. So the data is actually quite mixed. There is some evidence that suggests that pregnancy and even the number of children that a woman may have in their lifetime can potentially affect cognitive health. There actually is data to show that there may be a protective effect on cognition in patients with a certain number of pregnancies. It's actually very interesting. Most of the data suggests what we sort of describe as this U-shaped curve. So in patients that have less pregnancies and in patients with more than 5 pregnancies, they actually may be at a slight increased risk of adverse cognitive health outcomes later in life, comparatively to those patients who sort of fall within this having 1 to 4 children. It's very interesting, though, because it's difficult, sort of like Dr. Nestler and I had spoken earlier with his question, it's difficult to really discern the difference between the physiologic and physical aspects of pregnancy versus more of those environmental and psychosocial aspects that are associated with parenthood. And so understanding that patients who may have more children could potentially have more stressors versus those with less children. And is that really the thing that's sort of affecting cognitive health? These are the questions that we don't know the answer to, and we need to sort of do better in focusing on really disentangling the difference between the potential hormonal effects of pregnancy itself versus those environmental and psychosocial effects of parenthood in general.
Mhm. We had several questions from the audience, and again, let me remind people in the audience to please put your questions in the Q&A function. Several people asking about other conditions and how they're affected by pregnancy on the one hand and menopause on the other. So, for example, migraines was one question, and psychosis, or a loss of reality, a psychiatric class of symptoms, were two questions that came up. Let's start with pregnancy first. And Chelsea, maybe you could comment on women who have migraines, what happens with those migraines during pregnancy, and then we maybe talk about psychosis as well after that.
Great. Yeah, so actually it's quite interesting. Women who have migraines during pregnancy, many of the time will actually have improvement in their symptoms during a pregnancy. And there is some thought about hormonal changes that occur during a pregnancy and the connection to women who have a certain type of migraine, and is that potentially the reason behind migraines improving during pregnancy? Some women do experience worsening migraines. It's difficult for us to sort of predict or discern who might have less symptoms during a pregnancy versus those who have more, but oftentimes we actually find that women will have improvement in their migraine symptoms during a pregnancy. But with that being said, we also know that patients who have a migraine disorder are also actually at increased risk of preeclampsia or high blood pressure pregnancy. During the pregnancy as well. So that is something that, of course, we discuss with the patients that sort of the physiology behind migraine headaches can also put patients at risk for preeclampsia.
I was not aware of that. So women in that with a migraine disorder would be under greater scrutiny and surveillance for their blood pressure and other symptoms that might indicate preeclampsia?
Yes, exactly. Yep.
Wow. And what about psychosis in pregnancy?
So oftentimes,
Postpartum.
yes. So what we do know is patients with psychosis or psychiatric disorders prior to pregnancy, we know that sort of the most tenuous time when things could worsen in terms of symptoms is during what we would describe as like the postpartum period or the intrapartum period. So right around delivery and immediately after delivery. of course, think there are psychosocial aspects that are associated with the changes of having a baby and transitioning to motherhood that can potentially be associated. Also, there's just physiologic shifts that can occur during or immediately postpartum. But realistically, our bodies sort of think we're still pregnant for a time period after pregnancy. And so we also can see that there's this up spike in potential symptoms in that 6-week to 12-week time period postpartum. And so it's incredibly important as obstetricians or gynecologists that we continue to monitor these patients and follow up with patients very closely in that postpartum time period, understanding that that's certainly the most common time period that symptoms may.
Yeah, no, and just to underscore that, it's such an important period in a woman's life to pay attention to their mood and other symptoms, and for them to seek help if they are having any difficulties in the postpartum period. Yeah, thank you very much. So Dr. Barbieri, what about menopause and migraines? There are a couple of questions in chat about that.
Sure. So we know that women may certainly have hormone fluctuation associated migraines. So for example, some women will have menstrual migraines, which we think are due really to fluctuating and actually dropping levels of estrogen right before one's menstrual period and low levels during. And in perimenopause in particular, if I put up a graph of what estrogen does and a picture of a roller coaster from Six Flags Great Adventure, we would not be able to tell a difference here. So if you think of that, there's just so much fluctuation during this time period that we think that is what's responsible for the uptick in migraines. But again, we don't quite know, is it just fluctuating estrogen? Is it fluctuating progesterone? And how do these hormones interact with one's larger life environment? And this is what this psychosocial model is. And I love it because it does attempt to integrate all these different factors. Perimenopause is a time in life when women face an increasing amount of demands, responsibilities, and stressors, right? Often we're taking care of families, aging parents, work full-time, not to mention kind of the modern line for all of us, men or women, are literally bombarded with stimuli that we have to respond to. I haven't even touched my 4 emails accounts today. So that's just an example of that. How much of that is a stress to cause a migraine versus hormonal fluctuations, or is it both of them, and what do we do with them? And one other thing I would like to add here, migraines for a long time were considered to be a contraindication to hormone therapy. That is no longer the case. And while we don't use oral estrogen, for example, birth control pills, typically for women with migraine with aura, lower dose, especially estrogen that's delivered transdermally or through the skin, does not seem to increase neurologic risks of migraine. So there are certainly patients for whom we do use hormone therapy with migraines.
Excellent. Thank you very much. Dr. Shah.
Yeah, this is great. Obviously, some of my research, I do a lot of work on healthy lifestyles, and there's been a lot of focus on healthy lifestyles with Alzheimer's disease. I wonder, Dr. Pereira, if you could comment on, some of the recent findings we've seen, even anecdotal cases, right, of people making major changes in their lifestyle and seeing a lot of improvements. Where is the state of the evidence with regards to that?
That's a great topic, and I think it's always important to emphasize things that we can intervene on, right? You can't change your genes, but all the things you can do. So physical exercise is critical for brain health, for mood, for cardiac health, and same vessels, blood vessels that are in the heart, they also go to the brain. So treating vascular risk factors, so make sure you're treating your high blood pressure, your dyslipidemia, cholesterol, if you have diabetes, make sure it's well controlled, because it increases risk of Alzheimer's. Is once you get it, you develop much faster if your diabetes is not well controlled. maintaining social stimulation, cognitive. We saw that a lot during the pandemic, how critical keeping socially stimulated it is, keeping cognitively stimulated, learning new things throughout your life. Mediterranean diet, there's evidence that it's protective for brain as well as heart. So those are all critical measures that we should start now in middle age and keep it throughout our lives.
That's a great answer.
Dr. Pura, while you're spotlighted, let me ask a follow-up question of you as well. We've had several questions from the audience about sleep, and I know that this happens to be a specific interest of your lab. What can you say about the relationship between sleep, brain health, and perhaps risk for Alzheimer's disease?
Thanks, Eric. This is super important, right? We spend so many years, so much time of our lives sleeping, and it's such a critical period. So there's a lot of evidence, for example, that patients who have sleep apnea, and actually is much common in the elderly, they have increased risk for Alzheimer's disease. When you have sleep apnea, you have two things: sleep fragmentation, wake up a lot during the night, and you also have hypoxia, this low oxygenation that goes through your body. And actually, our lab was the first to publish showing that if you have intermittent hypoxia, you have an increased risk of having that tau protein pathology that I mentioned before to propagate from one neuron to the other, and which increases your risk to develop Alzheimer's disease and increase your progression of Alzheimer's disease. So I think sleep disorders are underdiagnosed, and many patients, not only those who are obese, are at risk of that, because in the elderly, the muscles in the neck become more frail. You tend to obstruct your airways at night, and there are good treatments for that. There are sleep apnea machines and other devices you can place in your mouth. So having a healthy night sleep, it's really super important. Sorry, go ahead, Dr.
I was just going to say, so for women who are having difficulty sleeping, insomnia, or other types of issues, what do you suggest they do to improve their sleep?
Right. I think seeing a sleep physician or the health system or one of us is important, because you can evaluate as a whole your sleep hygiene, right? So there are many factors that can be affecting your sleep. One is hormonal changes during perimenopause, as Dr. Barbieri is saying, and even hormone therapy can potentially help if that's the cause. We want to make sure that you are ruling out other causes of sleep disturbances. We don't want to miss out a diagnosis of sleep apnea that could increase the risk of Alzheimer's and cognitive and mood issues. There's a lot of insomnia and other factors that there are a lot of strategies. Make sure you're not drinking caffeine late at night, you have a routine. So there's a whole approach to be taken. And in particularly, I know there's a lot of media about ApoE4 carriers. Those are the highest risk for hypoxia, for Alzheimer's, and etc. Actually, our lab is also working a lot on ApoE4 and trying to understand. We're finding there's an inflammatory pathway of microglia in the brains of patients with Alzheimer's that really make more vulnerable in ApoE4 carriers than others to a lot of those pathologies. So if you understand better the biology of it, we can potentially try to intervene that in a more effective way.
And then just quickly, one of the audience members asked a good question. How do you find out what variant of ApoE you have? So if I wanted to know if I had ApoE4 as a risk factor for Alzheimer's disease, how would I get that genetic test?
Well, it's a great question. There are blood tests you can do for that. I usually advise patients to go through genetic counseling, because the implications for yourself and for your family, to make sure if you really want to know that, because we don't have immediate therapies that target ApoE4. And sometimes I have a lot of patients who discover 23andMe and one of those genetic testing, and they become extremely anxious about all of this. Some people want to know, others don't want to know. So I think I recommend, we have an amazing genetic counseling team here that I can suggest. But many of people come to me already knowing through many of those areas. And some people think if they know they're going to be healthier, go more to the gym and etc. But other people become quite anxious. So you just want to make sure you really want to know. We also can do that here at Sinai easily through our laboratories. We can test ApoE genotype. So they are ApoE2 allele, that's protective. ApoE3 is neutral. ApoE4 is a risk. Right. So if you carry one allele of ApoE4, you have an increased risk of about 5 times to develop Alzheimer's. If you carry 2 alleles of ApoE4, we have been thinking so far that we increase the risk about 15 times. But there's been a paper that you probably read in the New York Times last week that proposes that it carries as much weight as some form of genetic deterministic Alzheimer's. I think this is still to be replicated and thought a little bit more, because I think the cohort was a billion Alzheimer's cohort. We want to make sure this is also true in a population-based cohort. Right. So, but I know I'm getting a lot of calls about that study.
No, I know it did get a lot of play, and it's obvious, as you say, it's personal decision on whether a person would want to know that information or not at this point. Dr. Barbieri, would you like to comment also on the question of sleep and around menopause and related issues like hormone replacement therapy? You're on mute. Happens with every webinar.
Sorry about that.
Yeah.
So, I certainly do a lot in the field of hormone therapy, but menopause is not just about hormone therapy. It is a natural transition. So I also want to, address this issue of, I think with so much media attention to hormone therapy, and I do think hormone therapy is a wonderful tool. The reality is that some people simply don't want to use it. And some women may not be good candidates. We have a lot of women who may be at very high risk of breast cancer, or those who have hormone positive cancers, including breast cancer, for whom hormone therapy may carry increased risk. So I do want to emphasize that there are lots of strategies for sleep that don't involve hormones at all, whether they be behavioral, surrounding around metabolic health, nutrition changes, lifestyle, sleep hygiene in terms of temperature, sort of setting your circadian rhythm with light exposure and then maintaining a darker room environment. Things like avoiding alcohol, that's a major benefit to sleep. There are some studies that show that even one glass of wine can affect sleep pretty profoundly. This is especially true for women in perimenopause when alcohol metabolism changes. There is things like CBTI, which is CBT or therapy for insomnia specifically. There are some supplements that have been studied for sleep, and especially for those women who may have had hormone positive cancers, we have to be careful about choosing between them, because some of them may not be proven, some of them may be all marketing, and some of them may have hormonal action. So it's really important to distinguish between them. And finally, there are medications for sleep, and there is a number of them as well, and we have some choices there too.
Thank you. Dr. Shaw, I'll turn things back to you.
Sure. Let's bring Dr. DeBolt back into this discussion, and Chelsea, as you approach somebody who has had a prior pregnancy, what are your kind of mental health kind of issues or cognitive health issues that you think about and discuss with the patient who's had a prior pregnancy?
Yeah, I think it's, again, we had talked a little bit about it before, but the postpartum or post-delivery period, I think, is equally as important as during the pregnancy, and then also equally as important as it sort of shifts into the preconception period again, where someone is contemplating the next pregnancy. It's important for us to sort of I think as clinicians do an even better job of asking patients the tougher questions in terms of their mental health, really doing a better job at screening for depression and anxiety and psychosis and these things that really can make a huge difference in a patient's life. And understanding that pregnancy, while it is just one time period in which there are significant transitions mentally for a patient, that could potentially, as we've been talking about, have these long-term effects later in life. And so as to not ignore this time period of this transition into parenthood is really, really important, I think, moving forward. Important for understanding future cognitive health has been discussed by everyone here, especially when we don't have a lot of information or we're not really paying attention to that midlife time period a lot of the time, which oftentimes now is a crucial time when someone may be a newer parent, as people are often putting off pregnancies till a little bit later in life comparatively to prior. And so we really need to turn our attention and focus into this midlife time period as well, in order to better understand cognition and how pregnancy can sort of play a role in that. And so when discussing with patients, like I said, importantly, it's really essential to discuss patients' sort of the mood, how they transition, their support people. So that's also, I think, very important, because not only does stress sort of play a role in the postpartum period or transition period, but also things like resilience and understanding a patient's sort of full picture, I think, is really important. And part of our jobs as we sort of move into this like holistic experience for a patient, to better understand and help patients at that time, and also to understand risks in the future.
Yeah, that's great. Maybe I could just take one more question and ask about a woman who's had a prior pregnancy loss. And, I think that's obviously one where, a lot of anxiety and maybe you could kind of talk a little bit about our Rainbow Clinic just for a moment.
Yes, absolutely. So as Dr. Shaw said, this time period after a pregnancy loss, for whatever reason and at whatever point that loss may have occurred, is a very sensitive time period for patients when they do get pregnant again. And so our Rainbow Clinic is incredibly dedicated to taking into consideration a patient's mental health and well-being to get a patient through a next pregnancy. While I think sometimes from the outside looking in, this looks like a very exciting time, and someone may have this transition period where they're very obviously happy and excited to be pregnant again. But it's very important to understand all of the anxieties and memories that come along with being pregnant again, especially after a loss, and understanding that what that patient may need can, of course, differ from patient to patient. And so the idea of the Rainbow Clinic is to, as best we can, give as personalized care as possible, and so be able to let the patients know that whatever they might need, depending on the time period during their pregnancy, which again, a difficult time will differ from patient to patient. And so all of the providers in the Rainbow Clinic really being in tune to that and trained in that aspect, and of course understanding the psychosocial aspect for patients, and learning so much about the prior pregnancy, the baby's name, how you want to be referred, right? These people are still have experienced a pregnancy, and they may want to be referred as mom and dad, even though they may not have a living child. And so that is so incredibly important for us to understand. And again, so much, while the pregnancy itself may be healthy, right, from the outsider's perspective, the mental aspect that goes into a pregnancy after a loss is incredibly important, and part of, our goal at the Rainbow Clinic is to do our best to educate other people about how to best take care of these pregnancies, and then, of course, do whatever we can to support patients through that.
Great, thank you. I'll turn it back over to Dr. Nestler.
Thanks, Leslie. A couple of questions came up, and I think these were referred to in your introductory comments about differentiating between the normal symptoms of menopause. I think sometimes people refer to this as a brain fog, if that's a term that's used, versus early evidence of Alzheimer's disease or another dementia. Perhaps Doctors Barbieri and Pereira can talk about that, and how would you advise a woman who is experiencing some types of memory symptoms, brain fog, whatever, how would you advise them on differentiating whether it's menopause or whether it might be early signs of a dementing condition?
I'm happy to start, Dr.
Sure.
Pereira.
Yeah, go ahead.
So I think Dr. Pereira said it before. When women go through perimenopause and menopause, cognitive and emotional and sleep complaints tend to be their primary complaints, right? It's amazing. Like the ovaries can do so much. It's such a complex and beautiful system. And we come across this a lot. And I certainly see cognitive complaints as something that is very, very disturbing to a lot of women. So people frequently describe a brain fog in perimenopause and early in perimenopause with symptoms such as word searching, what was that movie? What was that actor's name type of thing? Loss of concentration, more difficulty with multitasking, sleep disruption, self-doubt that creeps in when you feel like your brain is not working the way it used to be, and sometimes loss of a little bit of emotional regulation, so mood swings with that. And for many women, it sort of leads to this fear of like, what is this? Am I going to get Alzheimer's? Is my brain slipping? Most of the time, it is brain fog of perimenopause and menopause. Although, just like Dr. Pereira said, there does seem to be a significance of this transition for future cognitive health. So I usually go through these symptoms with a patient, really trying to identify certain red flags. Brain fog of perimenopause does not mean, it may mean you left your keys in the room and you forgot where they are. It does not mean that you're somewhere out and you forgot where you live and you don't know how to get home. So it's really kind of the severity of symptoms and the impact of daily life. If someone has, for example, symptoms that impact their ability to take care of their family, deal with their personal hygiene and finances, these are real red flags, as is, for example, a family history of early onset Alzheimer's, so really prior to the age of, in someone's 50s. But I think Dr. Pereira is the real expert here, so I will defer to her too.
Yeah, so maybe Anna Pereira, you could talk just briefly, because we're running short on time, but about the work you mentioned earlier about biomarkers and efforts to diagnose Alzheimer's disease 10, 15 or so years before cognitive symptoms even appear.
Right. So for me as a cognitive neurologist, we have to put the whole picture together, right? So we have to have very good history. We do very outstanding neuropsychological testing. Mount Sinai has amazing neuropsychologists here, just give you a battery of testing for attention, memory, executive function, language, and you adjust for age and education. So patients in perimenopause are usually not in the impaired range, which have to have at least 2 standard deviation to the normal. So they usually have a mild attention issue, a little mild of memory issues, but nothing like in the impaired range. And as Dr. Barbieri mentioned, if you look into functionality of daily living, we also use brain MRI, structural brain imaging. We can look into the structure of the brain. All my patients have brain MRI. I learned a lot about the brain health just to look into the structure of the brain. And Dr. Nessler mentioned the amazing biomarkers in Alzheimer's, not only through imaging, we have amyloid PET scan, tau PET scan, we have spinal fluid assays that are being FDA approved for years and we use really well. And there's an emerging field of blood biomarkers. None of them are FDA approved yet, but some of the assays are quite robust, in particular phospho-tau217, that start rising early and predicts cognitive decline. So we really need to look into the whole picture and aggregate history, cognitive data, brain imaging, and biomarkers. So we are really in a transformative time in the field that you can really put all of this together to assess patients' risk and to diagnose better. And hopefully this is going to ultimately change the way we treat and the way we run clinical trials in a much faster, efficient way.
Excellent. So, we just have a few minutes left, and I thought it would be good to end asking each of you to very briefly, really less than a minute, tell us about one thing that you think the world needs to know about women's health. What's one thing that we could be doing at Mount Sinai, given the fact that we're about to launch new initiatives on women's health, that would have the most significant impact on women and their well-being? So we'll just go in the same order that we went in the original talk. So Chelsea, you first.
Great. So I think that and I've said it in my talk, it's really important to understand that pregnancy cannot be looked at as a standalone experience. Pregnancy is something that will affect women later in life, and to better understand the underlying biology of pregnancy is really what's going to help us to better understand those lifelong health effects that pregnancy will play a role in. And so better understanding, underlying pregnancy biology, I think in terms of clinical outcomes is really what's most important for us moving forward.
Thank you. Dr. Barbieri.
I think women's biology is fascinating, important, and complex, and our hormones, and we need to do more to understand it. We should be collecting hormonal biomarkers and other biomarkers on everyone across this transition. This is the era of artificial intelligence coming through, and we should be utilizing that to learn more fast.
Yeah, and it's just to underscore the importance of understanding female biology. Here we are in 2024, and there still is so much about the unique biology of girls and women that we don't yet know. Certainly emphasize that. Dr. Pereira.
On the same lines, I really think we are in a gap of studying of women's biology. There's significant sex differences in the immune system. We're in a higher risk of autoimmune disorders, metabolism, cellular clearance, gut microbiome. There's so many differences, and really need to also understand resilience and vulnerability. For example, women, they can carry a lot more of those Alzheimer's pathology without developing symptoms early on. So there's a lot to learn in terms of women's biology, so that you can treat women a lot better than we do right now.
Fantastic. Thank you. Dr. Shah, any final comments?
No, I just think there's, historically about 1% of NIH budget has gone to dedicated women's health. It's a crime and a shame. And we're all of you should be very excited to hear there's a lot going on behind the scenes here at Sinai, and a lot of things that we're going to stir up and change and make better and provide a lot of connections across specialties to enhance care and our knowledge about women, including bringing all experts together like this session. It was awesome. Thank you all.
Fantastic. Thank you. So on behalf of Dr. Shah and myself, I do want to thank our three panelists. I want to thank everyone for joining us today. I would like to make one final point, please. All of the clinical and research work that you heard about today were made possible because of extraordinary philanthropy. And as we've heard, the work has really just begun. So we need to give these talented leaders that you heard from today the resources that are required to make the advances that are so sorely needed in women's health. On the screen now, there's a QR or flow code. You could just point your smartphone camera at it, and it'll take you to a web page where you can support this very, very important work. Thank you again for joining us today, and be well.